professional. So the title of my talk, as Mo mentioned, is Public Health Surveillance for Changing Times. And the premise of this talk is that with increasing volumes of data that all of you in the room are aware of, it's important to assess the relative strengths and limitations of different data sources from the lens of satisfying a public health need, and consequently develop theoretical and practical applications and approaches that leverage these sources, with the ultimate goal, as all of us sitting in the room agree, is improving public health. The structure of this presentation, as I have currently designed it, is a brief overview. This is my personal introduction and background, followed by a small section on surveillance, on precision medicine, a little bit on translation, something about future directions, and then some time for our questions and comments. So let me provide a brief summary of who I am and how my lived experience connected with my research. And so, as Mo mentioned, I studied engineering in India with a focus on molecular biology and worked with a startup during my time at IIT Madras. I joined a boutique consulting firm right out of IIT, where I focused on oncology, dermatology, immunotherapy cases for like a lot of global pharmaceutical clients. And after a little over a year in consulting, I moved to an academic research institute where I conducted field research on maternal and child health in rural and tribal areas in India, working with different nonprofits. And based on the needs of my team, I pivoted to data science, working on machine learning and data visualization, specifically for undernutrition and micronutrient deficiency anemia. So I worked with Indian FDA, some startups, and different nonprofits. And then I came to Emory for my PhD. My PhD in nutrition and health sciences, where I studied the nutrition transition globally and focused on the role of health over the life course on obesity, depression, cognition, and happiness. So then I joined the Emory Global Diabetes Research Center, or EGDRC, as a postdoc and studied diabetes and hypertension epidemiology, and more recently as a CRT faculty member, their interplay with HIV and serious mental illness. So by zigzagging my way through the different domains of public health, I was able to gain a broader vantage of this wonderful discipline beyond traditional academic, government, and nonprofit perspectives, and was able to gain a first-hand glimpse of what it's like, what industry is like, and what startups are like. And consistent with the broader domains of public health, I believe that a persistent challenge exists and will continue to remain so because of the indeterministic nature of the soft social science that we are operating in. And the challenge that, as I have conceptualized it, is the following: that what is required, it changes really fast based on knowledge, and what is available changes very slowly, contingent on funding. Now, several major efforts are underway to solve this problem that many of you in the room have contributed to. These include, but are not limited to, the Global Burden of Disease Study, the NCD Risk Factor Collaboration, and the HPAC, or the Global Health and Population Project. But what about these emerging requirements? And as I pause myself to ask the question what these would look like, I think these include geographic precision, etiologic precision, and a focus on high-risk and underserved populations. So I sort of summarize these three big topics as surveillance with a focus on decentralized decision-making, precision medicine with a focus on subphenotypes of disease, and translation with a focus on technology. And the three independent and interdependent research questions that I ask myself are the following. Can we address gaps using alternatives to traditional surveillance methods, such as surveys? And how do we integrate precision medicine into disease surveillance? And finally, can we develop technology solutions with the goal of achieving health equity? These questions can also be simplified into the WH framework as where, who, and how. So in order to take my own fresh stab at answering these questions, I propose the following solutions and hope to build on these over the next 30 years or so. And to answer the where question, I was thinking of looking at small areal surveillance by combining novel data sources. The who question, identifying subgroups at the highest risk of adverse outcomes. And for the how question, identifying promising technology solutions for commercial translation. And I hope that these will feed into each other and inform each other. And hopefully over the course of the next 40 minutes or so, you'll be able to gain a broader vantage point in terms of how I think about public health and research. So I wish to share with you some of the recent work that I have done in the area of public health surveillance, specifically on using novel data sources for decentralized decision making. And a key context for these slides are that, as all of us know, there are major gaps in non-communicable disease care in LMICs, like India, for whom the public health system was traditionally and appropriately designed for diseases related to undernutrition and poverty. And what we observed here is that the prevalence of hypertension is high. Almost a third of Indian adults have hypertension, and 63% are undiagnosed, 82% are untreated, and over 90% are uncontrolled. Hypertension is a major risk factor for cardiovascular mortality, and the importance of controlling this risk factor is important for a young country like India that may otherwise not be able to enjoy its demographic dividend and will be stuck in a middle income trap that several other countries are already in or are heading towards. This study from the GBD project, published in 2017, appropriately titled Nations Within a Nation, underscores the significant diversity of the country, like India, with two states, Uttar Pradesh and Bihar. They roughly have the same population as the whole of the United States. And further disaggregating the national burden, we see that the ratio of communicable and nutritional diseases to non-communicable and metabolic diseases and injuries, titled the Epidemiological Transition Level, or ETL, is geographically very heterogeneous. Specifically, parts of South and North India have a higher burden of NCDs, while Central and Northeast India tend to have a lower burden. What I also appreciate about this framework, which the GBD team have designed, is that it allows for further disaggregation by groups of similar states, not just based on geographic clustering, but also based on economic and epidemiological clustering. And what we see is that intercepts vary substantially in 1990 for the disability adjusted life years by each subgroup, as expected. But also the slopes consistently are positive, and the proportion of NCDs are increasing over time for all these groups of states. So it's not like there are poor states and they only have these diseases of poverty. The non-communicable diseases are increasing across all states. Knowing this, let's disaggregate further what we know about these states. Below are the results in the India diabetes study published in 2023. And consistent with what is shown by GBD in 2017, we see that the burden of disease is higher for urban areas, for all these states, and lower, but still substantial, for rural areas for many states. The Indian policymakers and public health experts, cognizant of this heterogeneity, developed the National Multi-Sectoral Action Plan under this broader program called the National Program for Prevention and Management of Non-Communicable Diseases in 2017. This multi-component plan aimed to institutionalize NCD management at the district level. So we specifically want to focus on the third item, which is the implementation of revised standard management guidelines for NCDs. Now, a challenge remains. They want to do it at the district level, but there's no data at the district level. So in a viewpoint I led published this year, we highlighted that most studies were either representative at the state level or did not cover the population of interest at the district level. So all surveys before 2018 were either at the state level or stopped at the age of 54, which at the district level, but as all of us know, NCDs tend to pick up in the 50s. So the latest version of this one survey called the National Family Health Survey provided us with a unique opportunity to fill this data gap. And using this previously mentioned national survey, my team and I developed estimates for districts in India for key indicators of diabetes and hypertension care continuum. Specifically, we looked at prevalence, diagnosis, treatment, and control. And what we observed was that there was substantial variation, some of which is evident from these maps, in diseases and its indicators at the district level and below. However, there are two issues with this approach. The NFHS 5 survey is intended to cover individuals aged 15 to 54 years and their family members, and it doesn't capture older adults who are living by themselves. More importantly, although the survey enumerators use robust measurement methods for blood pressure, the measurements of blood glucose relied on random glucose that is fast and easy, but not appropriate for assessment of prevalence, extent of underdiagnosed and uncontrolled hypertension or uncontrolled diabetes. And the more appropriate hemoglobin A1C was not measured in LFHS 5. So let's specifically focus on the underestimation of prevalence and the overestimation of control. So along with some of colleagues from Georgia Tech, we decided that we could potentially combine different data sources together and to get better estimates of control. For this purpose, we used the urban city representative CARS cohort that Emory has been leading to develop a prediction model for HbA1c using variables that are available in the aforementioned survey, the National Family Health Survey. So we built a machine learning model to predict HbA1c using variables that are available in these surveys. And we applied this model to NFHS 5. And on the left are estimates of diabetes control using random glucose. More green implies higher control, which is the overestimation which I was mentioning. And more red implies lower control, which is the hopefully less overestimation or potentially underestimation that I'll be mentioning. And the red is the one which is, or the figure on the right is what we found out using the predicted values of HbA1c. As you can imagine, HbA1c is a unique biomarker. It has its own properties that well serves its purpose. So although we can potentially use correlations between biomarkers which are unrelated to each other across a causal pathway, using these correlations instead of mechanistic modalities and core biology to predict risk or progression of disease, we are susceptible to challenges of confounding and effect modification. Subsequently, we'll have poor generalizability to the same source population or like poor transportability to any other population. We specifically highlight the low predictive utility of these models in a holdout test set using some indicators, specifically the mean absolute error, the root mean square error, and the R-square. Furthermore, segregating this using the Bland-Altman plot at a 7% cutoff for HbA1c, which is a traditional cutoff for diabetes control, what we see is that there's a funnel shape. So as a model, the model tends to be very bad at higher values of A1c. As you can see, it tends to branch out. And at lower values of A1c, the model may somewhat overestimate it on average. That is, actual value is less than the predicted value. So from what we know, as HbA1c increases, glycemic control decreases. And so predicted estimates of controlled diabetes may be worse than the ground truth. That is, the actual situation may be better than what I had previously shown in the last slide. But what do we know about the USA? Currently, we do not know what are the rates of undiagnosed and uncontrolled diabetes and hypertension and other related diseases in USA by state or by county. So this graph shows the prevalence of diagnosed diabetes among all adults over the age of 20 in 2021 as part of the United States diabetes surveillance system. But who are we missing if we use only self-reported data for diabetes? So in a 2014 paper that Mo had led, it had shown that almost a third of patients who have diabetes are undiagnosed. And this was using 2012 data. And a more recent paper published in 2021 showed that the prevalence or the proportion of undiagnosed diabetes remains flat over time. That is, we have not made a lot of improvements in terms of reducing the burden. And who are we missing if we use only self-reported data for hypertension? We have almost a quarter of patients who are undiagnosed. This is among people who are 45 to 64 years old, who are untreated, and who are uncontrolled. Now, COVID-19 showed us the power of small areal surveillance. So in some work led by Dr. Shivani Patel, who's here, we had combined different data sources to develop interactive data visualizations to provide actionable insights for state and county policymakers for the general public in terms of understanding the burden and trends of COVID-19. Now, the current surveillance system for NCDs in the US relies primarily on modeled estimates of diagnosed cases from the BRFSS survey. And BRFSS is not available for Florida for 2021. So to fill this gap, we used data of 5.5 million patients from Epic Cosmos, which is an integrated electronic health record system, to estimate the proportion with hypertension in Florida. But still, these are only diagnosed cases because anybody who comes to the hospital, we know that they have these cases. Now, novel data sources may potentially be helpful, and this is where a combination of existing, known, and novel data sources may be useful for improving public health surveillance. So we're collaborating with Pursuant Health, which is a startup based out of Atlanta. They have kiosks in every Walmart in the US across about 2,000 counties. to estimate the proportion of high blood pressure among the users. We believe that we can combine data sources to produce better estimates of hypertension prevalence in US counties. And as you can imagine, there are many problems in using like kiosk data, but the hope is that we'll be able to figure out ways around this. Now, the current approach may lend itself to be successful. So what do we do after we have identified these populations at risk? Many of you public health practitioners would probably be thinking, you have all this data, so what next? So the current nature of gaps suggests a need for novel solutions. And our work, which was recently featured by the NIH, Today Show, and CNN, they offer some possibilities. So spousal co-occurrence of hypertension is also something which people have, several of you in the room have worked on. And using nationally representative data of older couples and young couples from 4 countries, US, England, China, and India, we showed that there is substantial co-occurrence of high blood pressure. This offers opportunities to design novel screening strategies and management strategies for treatment and control. Spousal co-occurrence of hypertension is also high in racial and sexual minority couples in the USA. For instance, we see a high burden of hypertension in Black heterosexual couples in red, and sexual minority men and sexual minority women couples in the figure in the bottom right. Yet still, this doesn't tell us much about what it might be more useful for. So is it screening or is it management? So my initial hypothesis was that, informed by the previous results, was that if you can screen individuals who have a family member with hypertension, you may be able to identify people who do not have hypertension, or rather who have undiagnosed hypertension. And at least at the national level in India, we have some clues as to what this may be. And so we observed that compared to those without a family member with hypertension in green, those with any family member with hypertension, they have a higher burden of disease. The black line here indicates the burden of undiagnosed hypertension among those without a family member with hypertension. So we first try to understand if it's useful to screen people, if anyone in the family has hypertension. And what we observed was that diagnosed hypertension tends to cluster in families. That is, if your family member is diagnosed, you're more likely to be diagnosed yourself. But more importantly, if your family member is undiagnosed, you're also more likely to be undiagnosed. So the original screening strategy that I had in mind, that may not work. And we may need to rethink how to best improve our care cascade for hypertension in India. So potentially we could screen families of those with newly diagnosed hypertension who say that they don't have anybody in their family with hypertension. It's possibly one approach. Now, using existing secondary data in creative ways, holding true to robust study design, it offers several possibilities and opportunities to estimate other indicators among vulnerable populations who are traditionally underrepresented in surveys and cohorts. So I show in papers that are currently under review that the rates of prescription for different weight management medications among people who are eligible for them are low in a vulnerable population who are receiving second-generation antipsychotics. However, what is interesting to note is that the trend of semaglutide and tirzepatide prescriptions are going up since they have been approved for weight loss. These are all people without diabetes. And using observational causal inference methods, we show that if these semaglutide or tirzepatide are prescribed, they induce weight loss that is inversely proportional to the risk of weight gain from the antipsychotics itself. So there are some antipsychotics which tend to cause a lot of weight gain. So what we are showing is that if you have a higher propensity of weight gain from these antipsychotics, you may lose less weight compared to a low propensity antipsychotic. We can also use EHRs to study NCD management among those with HIV, such as what we show here for patients from Grady Memorial in Atlanta. And also to track emerging risk factors for different diseases. So using electronic health records from One Florida Plus, we showed that exposure to COVID-19 was associated with a higher risk of type 2 diabetes. But the BMI at the date of infection was higher among those who were exposed. So if it is causal, we do not know yet. EHRs can also potentially help us to identify more precise cascade indicators beyond the traditional diagnose, treated, and control that we have done. And this can specifically help us in looking at how standards of care are adhered to in different populations. So what we have shown here is that Patients who are belonging to rural areas, who are Hispanic ethnicity, and who have poor or unknown diabetes control are less likely to meet standards of care and may be more likely potentially to progress to vision-threatening diabetic retinopathy or even blindness. The second part of my research is related to precision medicine, specifically how to integrate precision medicine with disease surveillance. So, a study published in 2018 led by Dr. Emma Alquist from Sweden combined data from 3 clinical phenotypes of diabetes, that is type 1 diabetes, latent autoimmune diabetes in adults, and type 2 diabetes. He further stratified into 5 data-driven clusters using 6 variables. Specifically for type 2 diabetes, there were 4 subphenotypes, which are severe insulin deficient, severe insulin resistant, mild obesity related, and mild age related. So a challenge which I will mention again later is that the variables which are typically used to cluster these are not routinely measured in clinical settings, preventing widespread clinical translation. So for example, HOMA2-IR and HOMA2-B require either fasting insulin or fasting C-peptide and fasting glucose, which are typically not measured in these settings. But what followed was substantial excitement from the research community that these novel subphenotypes are clinically meaningful, and over 50 studies, including 6 in the USA, that replicates these in different populations. So the first of these kind used like NHANES, and they replicated that these phenotypes are present, and they may have a slightly higher burden among minorities. Now, data-driven classification of diabetes is not new. And what I highlight here is a paper from 1992 that showed that diabetes can be stratified using 3 variables, area under plasma glucose curve, area under plasma insulin curve, and steady-state plasma glucose response. However, the ANDIS study, which is a study from Sweden, it spurred everyone, I believe could potentially be explained by Dr. Larry McInerney, who had no relation to the study, but he had some indications of it. This is nothing will be accepted as knowledge or understanding unless it has been challenged by someone competent to challenge it. And the main function of nearly all academic work is to help readers understand better something they want to understand well. And whatever science that we do is a bunch of conversations moving over time. And this study challenged the dogma and made people rethink type 2 diabetes beyond the ongoing conversation. So she and her team, they added robust data to this conversation. Now, what did everyone find out? Mild age-related diabetes was the most common subphenotype in all replications. In non-Asian, predominantly white European populations, the severe insulin-resistant phenotype was more common than the insulin-deficient phenotype. And in Asians, the severe insulin-deficient phenotype was more common than the insulin-resistant phenotype. The major gap remained despite these replications, and none of the studies so far enabled public health researchers like you or me to translate these findings to routine care. This is because in the US, less than 0.5% of newly diagnosed type 2 diabetes cases have fasting glucose and fasting insulin measure. So we are addressing this. So we harmonized 6 cohort studies in the US. We conducted de novo clustering analysis to replicate these subphenotypes. We built prediction models using variables collected in EHRs. And we applied it to newly diagnosed type 2 diabetes in electronic health records. Almost 700,000 cases. And here we present the proportion of cases of newly diagnosed type 2 diabetes that are severe insulin deficient and by race ethnicity. And our results are consistent with others that suggest family burden in racial and ethnic minorities. And what I present here is one way where public health and precision medicine can come together to leverage the latest findings in precision medicine to influence treatment decisions and care outcomes. We also present the maps of the mild subphenotypes of type 2 diabetes, the mild obesity-related diabetes, and the more common mild age-related diabetes. What is well known is that 80% of whole genome samples and genome-wide association studies are predominantly on participants of European origin. However, majority of diabetes cases, almost 70 to 80%, are in LMICs. So our work showed that probably less than 10% of precision medicine research is from non-European populations. So I want to spend a few minutes to touch on the potential for our research to make a significant difference through commercialization and partnerships. The Shankar Fellowships and the Diabetes Translation Accelerator provides up to 5 years of stipend insurance coverage for MD PhD students. The goal is to launch the PhD as a startup, hopefully coming out with high impact, affordable solutions, strong entrepreneur teams, and sustainable startups. We'll be leveraging several internal expertise and entrepreneurship capabilities within Emory and collaborate with external technology partners like Georgia Tech and IIT Madras to achieve this aim. Now, as we were working on selecting these fellows, we asked ourselves 3 questions. How technically feasible is the project? How great is the need? And how capable is the team? So we selected 3 innovators who we believe will move us one step closer to reducing the burden of cardiometabolic disease globally. There are other stakeholders who we can work with to achieve an aim of health equity. So I and Dr. Elizabeth Rhodes here represent EGDRC in the Coalition for Access to NCD Medicines and Products. And we believe that there is significant benefit for current students and faculty at Rollins and elsewhere. So the coalition is a group of government agencies, industry partners, global NGOs, philanthropic foundations, and academia, with the goal of improving access to medicines and new technology for diabetes, hypertension, and cardiovascular disease. By working with different stakeholders beyond government, academia, and nonprofit, I believe we can make our impact multifold. And we can also figure out ways for our MPH and doctoral students to leverage their existing training in statistics and epidemiology, large language models, and data visualization products to improve the functioning of these different stakeholders. Addressing key priorities in precision public health through technology solutions, that's how I thought I should frame my mission statement. And in summary, my current research and practice intertwines itself to addressing key priorities in precision medicine and public health. So with the goal of leveraging technology as a conduit for health. So I continue to generate preliminary data to support 3 R1 applications listed below. First is related to subphenotypes of type 2 diabetes. The second is related to reinforcing conditions such as HIV and serious mental illness. And third is identifying technology-enabled strategies for improving access to prevention management in rural USA. So here are a list of active papers that I'm working on with faculty and student collaborators who are listed with a star. Now, several of these papers try to feed into the different R1 applications that I had mentioned below. And in summary, I want to leave a lot of time for questions, but in summary, I want to quote Sir Peter Medawar, who has inspired a lot of my way of thinking about science. He speaks about science as the art of the soil. And so I have touched on geographic precision and how we can leverage different data sets to estimate different useful indicators in space, etiologic precision to think about subtyping a disease, working towards clearly defined problems by merging the two, and potentially working on technology solutions, such as Diabetes Translation Accelerator. The final aim of developing a feedback loop to improving geographic and etiologic precision through partnerships and collaborations. So I want to acknowledge many of you in the room, as well as those listed on the slide, and any omissions and mistakes are entirely mine. And I want to end with another Medawar quote, which is, just because I'm a scientist doesn't mean I'm an expert on ... There's a formula for all seasons. Questions? Thank you.
Thank you, Jithin. So we'll open up for questions here. I know we have several people on Zoom, but maybe we'll start with the people who've taken time and effort to be here in person. And I'm sure there'll be people on Zoom too.
Thanks, Jithin. I'm not sure I understood all of what you were talking about, but let me give it a try. When you're talking to policymakers, in India, for example, at either the district or the state or provincial or national level, how do you translate all of these graphs into statements? Not that these are stupid people, but they're not involved in the mechanics or any of the other research, they're not researchers. They're saying, so what does this mean for me? Either in terms of resource allocation or long-term training. I'm just curious if you've been involved in those kinds of conversations and how you've made the translation.
Thank you. So, my
Just one second. Can people on Zoom hear the question? Just to make sure.
Yes. Yeah.
Yes.
So, my first foray into public health, as I mentioned before, was at St. John's Research Institute, where I worked with different stakeholders, nonprofits, academia, government. And the first project that I embarked on with the government was working with the Indian FDA to develop dashboards that are easily interpretable, using good design principles, well documented, so that anybody who wants to check specific indicators can go and look at them. Now, this cannot be done in isolation, as mentioned. And it required a lot of back and forth stakeholder consultations. We met with them very regularly to understand what they needed and try to find out, are these the indicators that you're looking for? Do you need us to define it better? Do you want us to document it better, etc.? But why I pulled up this slide was because for both these papers, which I had listed at the bottom, we developed dashboards for policymakers. Primarily because it's the first data that we have, or rather first data that is available at the district level for India. So we tried to use some design principles, not exhaustive because it is just a pilot dashboard. And the hope is that go to these dashboards and use it. So I try to have an interpretive element to most of the research that I work on, either through graphs or through dashboards.
So thank you.
Hi, Jithin. Great talk. And congrats for coming this far. And one question I had, so, I worked on the spatial GBD project, and everyone loves the first map you make, and then they get bored of it. So, unfortunately for my team. And so in your feedback loop, technology progresses at a very rapid scale. So, I guess in terms of a research program, do you have any ideas on how to keep this geographic precision fresh? Because ultimately, if you're not directly measuring these things and you're usually using regression, the maps become quite stable and all these things are quite correlated to each other.
Oh, it's an excellent question.
Yeah.
So Ani's question, and if I able to summarize it correctly, is how do you account for the temporal drifts in the data over time, especially because data doesn't come in at such a rapid pace. And even many of these maps that I have shown have wide uncertainty intervals. So how do you know that what you're seeing is you don't? So at least something which I have understood is it's better to provide good enough information in the beginning and get it validated rather than no information at all. So I believe there are multiple steps to this, but the ones that I can immediately think of are using data sources that have a good refresh rate. Epic Cosmos, which some of us in the room are already using, is one such data source. It provides electronic health records for 250 million Americans from all 50 states and the territories, refreshed every 2 weeks. Pursuant Health is a startup. It has 80 million sessions that has measured high blood pressure, that measured blood pressure and body weight over the last 6 years. So using that along with the existing surveillance system, I think is the future, as opposed to saying that our estimates are true. So I believe I'm very cognizant about this reality, and I agree with you. There needs to be a lot of work done in terms of data fusion, in terms of capturing the uncertainty, associated with temporal shifts as well. So that's where I believe that collaborations are essential. So thankfully, we are blessed with an amazing biostats department with experts in spatial modeling.
I had a question. Great talk. So many interesting things. So actually I have 10 questions, but I'll stick to one. I was wondering if you could talk a little more about, I was intrigued by the Walmart kiosk project. It was something I could relate to. So yeah, I guess just the kind of data you get, what are kind of the pros and cons, limitations or advantages that you see to it as well?
Sure. So Thomas Yao, my stats PhD student, and I, we're working on this with this startup. So Pursuant is doing some amazing work. So they have figured out how to scale to all Walmarts in the country through partnerships. And they have two kinds of data. One is like self-reported data that you can click and, you have like a screen displayed. They can they can plug in remotely what questions should be displayed. But also they have like a blood pressure cuff that you may have seen. It's there in several of our, like gyms also. And they have sensors to measure body weight. Now, the good thing about the data is that, the pace is very rapid. The bad thing is, as you can imagine, it's full of like selection bias. So like, who is it that goes to Walmart? Who is it that, puts their arm in the blood pressure cuff? Who is it that chooses to answer which module? So this is where I feel there's a lot of scope for methodological development, especially first in terms of comparing how is this data compared to these different data sources. So you have surveys, you have EHRs, then you have these kiosks and other sources also, but these three are the ones which have the most granularity. And then potentially like identify what are the best things that we can pull from each of these different studies or different data sources to estimate our indicators of interest.
Do the kiosks ask any information from the users about themselves, like their age or race?
So they have like a detailed consenting process. All data is like securely stored, and they also have information in terms of like demographics, preferences in terms of like do you regularly eat fruits and vegetables, or how many hours of sleep do you get, things like that.
Okay, so you do get some more information.
Yes, we do, yeah.
That's cool.
Which we can use as covariates in our spatial models. Very good.
So, great talk, very enjoyable. So one of the things I wonder about a lot, because, I'm involved qualitatively in assessing some of these tools, is this constant concern in the literature that both AI models and the delivery of technology inherently just exacerbate inequalities. What are your thoughts about how we can use this better to improve equity in health access, healthcare, health outcomes?
It's a very difficult topic. I don't know if I'm like qualified to speak on AI and ethics. I can take a stab. So I do believe that when companies like ChatGPT make their data models like completely open source, yes, they have like done a lot of like potentially data capture which may not have been agreed on by different policies. Free models which they have released are still useful for the public. They do not have certain features, but I still believe it is better than not having those models. That said, I think any technological development, just in terms of like the saturation curve or like the adoption curve, always tends to favor people who adopt it first and the people who have the money. I mean, that's like just been the historical precedent for any technology. So I do not know if AI will be very different. It could be that the best models for personalized nutrition or for personalized medicine would continue to be favoring those who are the wealthiest, followed by those who. I think eventually it will percolate. It might take less time than some of the other technologies, but still there will be that curve as far as I understand.
You have one question online. Felix.
So Felix's question is, you guys can see, how would an ideal diabetes surveillance system look like that meets the needs of public health authorities and policymakers? How might that differ from what we have diabetes cases? So, thank you, Felix. This is a good plug for this viewpoint that I wrote, The Lancet Diabetes, where we actually talk about an ideal diabetes surveillance system. I feel it needs to be more real-time and it needs to incorporate non-traditional data sources. It also needs to capture data on complications and several other facets of diabetes that we typically don't think about in surveys. Mostly from the time point of like interviewer burden and responder burden. So happy to share this paper with you after that.
A really nice talk. Mainly just a few plugs for ideas which you might or might not comment on right now. One is with respect to precision. Of course, precision is very hard word. Nobody wants to do the imprecise word. So that would be a very hard paper topic. At the same time, I was thinking that given your interest and your expertise, you mentioned geographic precision, you mentioned etiologic precision. I think it'd be really fun to add false precision to the topics that you address, because I think it does. There is a propensity in a lot of research, including the GBD and others, to introduce effectively false precision. I think you have something that you could say about that. I may not necessarily want to say it right now. But the other thing that comes to my mind, especially when you're thinking about the family history as risk factors, is something that Cecile Janssen, who used to be on faculty and unfortunately passed away, but she and I started to think about how do we use family history in the context of shrinking families, right? So a lot of work from her background was in cancer work. I think it also applies to a lot of the work that you do, is really reliant or has been on the information that we get from families, which are shrinking. So all of a sudden you have many families that don't have brothers, sisters, aunts, uncles. What do we do from there? So could be continued if you're interested.
Sure.
Yeah, I appreciate how you could cover this breadth of topics in just 20 minutes. You are uniquely qualified to do something like that. My question builds on your title, Public Health in Changing Times, or Public Health Surveillance for Changing Times. Wanted to get your thoughts on what implications these changing times have for public health training, and specifically global health training from your perspective. And if you could also specifically address the issue of AI in graduate student training in our department.
Thank you. So this is a topic which I am very passionate. So I believe the current way public health training is done, we have a lot of scope for like incorporating new technologies, specifically when it comes to things which can be taught but need not necessarily be taught by faculty who are busy with research and service. The two things that come into my mind are related to developing case studies that students can interact with the AI on and like work towards solving it. And the second is to develop homework assignments that people are already doing it at scale through these massive open online courses. Evaluation of assignments primarily driven by AI. Now, John, I and you have had like a very in-depth conversation about this in the past. But I do believe that case studies real-world case studies which use AI are important for training our new generation of public health workers. Then the challenge, if we do not use it, is that they may not be prepared when their job requires them to use LLMs or any kind of AI. That it's important for us to work on integrating it intentionally in our career. So examples are homework assignments, which potentially the first stage could be solving math problems by hand in class. Second, transition to coding with AI as a co-pilot, and so on.
So you commented over the course of your presentation, I remember, about, and this is something in this, definitely in the school mission of improving health equity, or rather addressing inequities. So can you have two related questions to this? How do you see these approaches addressing those from delivery of, say, interventions? Because all of surveillance is, you have a problem with addressing interventions, and you have. The second question I have, and so Matt Deb is here. When you're in low income, low resource settings, and I always tell students, we'll always have low resource settings because the resources may be low for what you want them to use it, it's used for something else, etc. So when in low resource settings, what is your vision of the efficient surveillance system? Are we going to have one for TB? Are we going to have one for diabetes? Are we going to have one for maternal and child health? Then something like COVID comes. Just where do you see? And you're familiar sort of with the district health dashboards in India. You've been trying to want your thoughts on that.
So just like resources, I believe efficiency is relative. It could be that systems which are not designed specifically with non-communicable diseases in mind, have an edge over traditional systems like the US, the UK, primarily because they can skip technologies. So it may be that India's new National Digital Health Mission may put it in the forefront of fighting non-communicable disease, primarily because they'll be able to link across different kinds of health systems. Yes, public first, eventually, hopefully private. And I feel efficiency is like, again, it's like multi-component. You can talk about process efficiency or like, model efficiency, or even about how data is coming into the whole system. I feel the biggest challenge which we might face going forward is we wouldn't know how to plan when you have these different interacting challenges and the health systems are not prepared for that. Like we saw during COVID where systems which were designed for like chronic disease care were not intentionally designed for like managing acute external shocks. So same case, we have all these different things coming in, like a lot of destabilizing influences which may come from AI, geopolitical conflict, from potentially new infectious diseases, and definitely from climate change. So I do not know if it's ever theoretically possible to achieve the kind of efficiency that we might want in like a academic space, but I do believe in practice we can use certain efficient practices which are general stakeholder consultations all the time, figuring out easy ways for data to flow bottom up and top down. So practice like that. So that's how I think about efficiency, not so much about efficient resource allocation or efficient solutions. I don't know, that's like a very roundabout answer.
Back to the kiosk, if you could share a little bit, how was the process of like partnering with them? If it was like easy, if you were looking for a new data source or they were looking for a partner, like from the perspective, if I'm a researcher here and I want to explore another, like a new different data source.
So this is actually made possible because Mark has like figured out a way to put EGDRC on the online space. So they reached out to Mark Hutchison, the managing director of EGDRC, and then we had to sign a data use agreement with Office of Technology Transfer. So the whole process was very seamless. So once we shared the data, we had some initial consultations, and then they shared the data with us. So it is not that hard. I think the good thing is we are able to show that we have enough in-house capabilities, not only to analyze data, but also to store it securely, so they don't feel that their data is threat of being lost.
Thank you.
Yeah.
So you talked a bit about basically a model that you use to predict A1C using various things, correct? So presumably, the question is about trying to understand in the end what I could learn from what the model is doing. So presumably at the lowest order, what it does is just say if the random glucose is high, A1C is high. Do you have sort of an intuitive sense of what like the next most important corrections that it uses are?
So we didn't think about uses beyond surveillance for this, but mostly because there are now easier ways to measure A1C. It's just that at scale, no one survey has done. So I think this gap is temporary, that in the future, studies that will be done out of India and other LMICs will measure A1C using dried blood spots that have their own issues when it comes to transportation, although this other modality has shown that A1C is fairly stable in settings which are not India. So the Health and Retirement Study out of the US has been measuring HbA1cs in dried blood spots since 2006. So I believe that that's potentially how we should be using it. This is just like a stopgap till we figure out other ways of measuring glycemic control better. So I wouldn't spend a lot of time on this model specifically, but it's just like a way to think of how to combine different data sources.
Another question. Yeah, so the goal of epidemiology is usually seen as to produce generalizable knowledge, and the goal of translation is to act on very specific knowledge of a particular problem. Do you experience any kind of attention, because your work spans epidemiology and translation and the way that it does, and also across global settings, et cetera, et cetera. Do you experience a tension and sort of like balancing these two goals, and if so, how do you navigate that?
So it took me a long time to figure out what I really wanted. So when I started my PhD program, a lot of my friends came in knowing that they wanted to work in maternal and child health or the same. So for me, it was like a journey of like discovery, jumping through like different diseases. So over the course of that time, I feel through conversations with you and several others that I was able to like refine my overall framework of how I think about health. And I've tried to make it comprehensive enough so that it tends to feed into each other. So like an integrated framework of knowledge in a way, but hopefully which is self-reinforcing. So as of now, I do not feel that discordance between surveillance and translation, but in the future, when probably like workload gets higher, I might. But as of now, it's doing okay.
I have one more question. It's actually a solving question. There was this issue. There's this issue of temporality that came. And when I've talked to a nutrition, and I pull up the anemia things, and I say, guys, it's even though the reference is 2019, these data are actually from the same graph from 10 years ago, etc. So there is that one. It's not just that it's changing; things are changing rapidly. That the data, in a country, so-called, I can say that, in a developed country like the US, okay, you have AHR, which is refreshing, and that's why it's in the low resource setting, they don't refresh. So that's one part, that things are moving at different rates. But the solving part of the question is, when you think of areas, geography and subgroup, how do you handle movement of people, migration?
Oh, so good question. The current way data systems, at least EPIC is designed, is that you're able to track across health systems that participate in that particular integrated ecosystem. So if, let's say, you go to Emory and then later on you go to like University of Florida, your data should ideally be captured in the EHR surveillance. Maybe it may not necessarily be well captured in both these systems because they don't share data that well. But at the end of it, in our integrated database, it should be available. But in a country like India, this is where I feel LMICs for whom development, or rather public health infrastructure is primarily designed for like one kind of disease, when they have the opportunity to shift to a new kind of disease, I feel they can leapfrog the siloing which is happening right now in countries like ours. An example is the National Digital Health Mission creates these ABHA IDs, which are like Ayushman Bharat Health Identifier, Health Account Identifiers. So these allow cross-linking between different public health systems in India. So if, let's say, I go to one particular state and move to another state, my health records should be easily portable, at least in the government system. So they're trying to incentivize private providers also to jump in on it. But definitely they have had massive success in rollout. So an example is some of the work that I'm doing along with Mo and Erica Coker, nutrition PhD student, is that we receive data from Andhra Pradesh, the whole state, 40 million patients, or rather 40 million people, 49 million citizens of the particular state. There was a massive drive under the last chief minister to get everybody enrolled in this government program. So everybody now has like a health identifier. This actually streamlines referral and tracking, and which will actually enable us to see how many of those people who were referred are actually following up for care, how many of them are receiving the medications in like a government pharmacy. So there's a lot of work to be done, but I feel LMICs may have an edge over high-income countries just because the infrastructure is not set up yet. So the interportability can be solved in these countries faster. Oh, sorry. Just like one last one.
Last one. Okay, I'm very honored. So very inspiring talk. Did a lot of information to take in and a lot of things to study. So it's very great to learn. You also have an interest in precision geographic surveillance. So I have one technical question, one general question. So we have a CDC-funded project, a multi-center project, to build a diabetes surveillance system using EHR among children and adolescent population. So one of the challenge we found using EHR to calculate the diabetes prevalence is not challenges to identify who have diabetes, but to determine what to use as a denominator when calculating this prevalence, right? Let's say if I take the one Florida as an example. So one Florida covers 60% of the residents in Florida. And when calculating the diabetes prevalence, should the denominator be everybody living in Florida or only that 60% included in the EHR, right? So if you include everybody, clearly it's underestimate because the system don't cover much. But if you only use that 60%, it's also a problem because people choose to visit the clinic by their choice. So I was wondering, in your analysis, using that one Florida piece to replace the brothels in Florida, what type of denominator you pick? So that's the technical question. In general, where do you see if it is feasible at all to develop this surveillance using EHR or not feasible in the future? This is the more general question.
Great question. So in terms of just for Florida, I use like Cosmos and my denominator where all people who had who visited a health system in the years prior. So it accounted for people who are like regular users of the system. That is my denominator. And the numerator was this computable phenotype, which has been published previously. So in terms of where I think it can be used, I feel it cannot be used in and of, but just by itself for, I mean, it's something which you have also like worked on, especially when it comes to your habitual users framework. We're trying to figure out how do you identify a loyal user for the EHR system. I feel one possibility is looking at proportions of building out specific estimates which can be used like prior to feed into other models. So it could be potentially be used to inform the BRFSS spatial model as opposed to using just this data independently. So I would say a national representative data set should always be the foundation, and whatever is left over should be like adding on to it to make better info, like to add additional information to it. So Sharon tells me it's time to wrap up.
Thank you, Jithin.
Thank you, Jithin.
Thanks.